going to wrap up this part of the meeting and move into manufacturer comments. So we have two manufacturers joining us today that we'd like to invite them to come up to the front table. Daniel Dorian and Alena Kuhlmeier. I've said your last name incorrectly. I apologize very much. Thank you. Well, welcome to St. Louis and welcome to the Midwest CEPAC meetings. We're glad that you came to be with us today. We try to limit the prepared remarks to 5 minutes. If you can honor that request, I would be most grateful. Then I don't have to wave you down or cut the power to your microphone or anything. So.
Good morning, everyone. Can you hear me?
Yeah, keep it tight just for the
sure.
for the radio audience.
Given the time limitations, I actually wrote down my comments so I could read them, not forgetting important points to make, and I appreciate the time and effort. So my name is Dan Dorian. I'd like to thank ICER for the opportunity to provide comment today. I'm an interventional cardiologist. I practiced in the Philadelphia area, primarily in academic settings for almost 20 years. My clinical career was dedicated to the medical and interventional care of patients with coronary and/or peripheral artery disease. As I mentioned this in the future, I'll refer to this as CAD, PAD. They're not necessarily interchangeable. It could be either or both. I am presently a senior medical director in medical affairs at Janssen Pharmaceuticals. As a former seasoned healthcare provider, I will provide clinical commentary. Rivaroxaban is an important, established, and therapeutically unique treatment option added to the contemporary standard of care for patients with chronic stable CAD or PAD. Numerous large clinical trials and registries have demonstrated that these patients have substantial ongoing risk, as mentioned earlier, of devastating and potentially irreversible cardiovascular events, including stroke, heart attack, limb amputation, and death. The ICER analysis further supports the clinical value of low-dose rivaroxaban with aspirin to patients with chronic CAD and/or PAD, and also demonstrates that rivaroxaban is highly cost-effective in this clinical setting. However, as a former clinician, on behalf of Janssen, I would like to share the following two concerns. Briefly, as mentioned earlier, ICER presented the data side by side and methodology and conclusions concerning rivaroxaban and Vascepa in the evidence report. Users of this information are not often clinical experts and may erroneously conclude that they are interchangeable. I would request that ICER explicitly state that the two drugs are not, or consider separating them in the report. But more importantly, while the ICER findings are supportive of the clinical value and cost effectiveness of low-dose rivaroxaban plus aspirin, the included comparison to dual antiplatelet therapy may lead to confusion and inadvertently encourage the use of an inappropriate and unproven therapeutic alternative, specifically clopidogrel. ICER mentioned the inclusion of DAPT in the CADTH and NICE analyses. However, it is important to note that the comparison to DAPT was considered inappropriate and thereby redacted from the CADTH report. Additionally, the NICE report explicitly states, quotes, clopidogrel is not a relevant comparator for the overall COMPASS population, unquote, and based its recommendation of rivaroxaban plus aspirin to a comparison of aspirin alone. The data in the ICER network meta-analysis is derived from a post hoc analysis of the charisma trial, a subgroup especially, importantly, had failed to meet its primary endpoint. Even the authors considered the findings to be only hypothesis generating. It is imperative to state that this methodology and reported findings should not be used for societal-wide decision analysis. By suggesting that clopidogrel could be considered as an alternative, it is potentially and inadvertently encouraging an off-label use of clopidogrel. ICER should consider redacting this analysis or explicitly stating this in the report. Lastly, I would like to conclude as a reminder that the COMPASS trial demonstrated unparalleled improvements never seen before for this patient population. This patient population is considered chronic and stable. This is not a patient population where clopidogrel or ticagrelor are utilized clinically. It is critically important to recognize the relative risk reduction of 24% in overall major cardiovascular events, a 1.3% absolute risk reduction. The individual components contributing to the overall improvements included a 42% relative risk reduction in stroke accompanied by a reduction in stroke severity. There was a 22% reduction in CV mortality, a non-significant reduction of 14% in myocardial infarction, a 70% relative risk reduction in lower extremity amputations for patients with PAD. Regarding the KM graph that was mentioned earlier, the curves distinctly diverge over time. Additionally, when one considers high-risk populations, which is what we do as clinicians when we're considering initiating therapy, when you look at that within the trial, such as patients with polyvascular disease, there is an absolute risk reduction of 3%. Regarding the trial stopping early, when there is a distinct improvement in outcomes, including mortality being observed, people on data safety monitoring boards are obliged to stop the trial prematurely. So that's why that was done. And I think most people, most clinicians, most ordinary non-practicing clinicians would also agree that continuing placebo is unethical in those studies when there's a clear-cut mortality difference. From my perspective as a former clinician, I am always keeping in the front of my mind the welfare of my patients and the ability to make appropriate decisions for the individual patient, their family, and their needs. When you sit or stand by someone who's dying and then engage the family thereafter, you'll understand what I mean. And as an interventional cardiologist, that is something, unfortunately, that I had to do more times than I enjoyed. Thank you for the opportunity to give comments on behalf of Janssen and myself and the patients we serve with innovative treatments such as low-dose rivaroxaban. I would be happy to address questions in the discussion session, particularly around, as mentioned earlier, the bleeding definitions that were used. Thank you very much.
Thank you very much.
Great, thank you. I'm battling a cold, so I apologize. Good morning, everyone. My name is Alena Kuhlmeier, and I'm the Associate Director of Corporate Alliances at Amarin Pharmaceuticals. I will be speaking on behalf of Amarin today. We thank ICER and the Midwest CEPAC for the opportunity to meet with experts, the public, and fellow manufacturers, and to share Amarin's position on ICER's draft evidence report. Amarin takes very seriously its mission of developing innovative, life-saving, and quality-of-life-enhancing medicines for patients and in conducting rigorous, high-quality science to clearly evaluate their benefits. While statin use and optimal medical management have reduced cardiovascular risk and improved patient health outcomes over the last few decades, substantial residual cardiovascular risk remains. This residual risk represents an important unmet medical need for patients and accounts for significant healthcare and economic burden. Since the publication of the results from REDUCE-IT, our cardiovascular outcomes trial, in the New England Journal of Medicine in January of this year, the landscape has been evolving rapidly. Given the enormous burden and unmet need in cardiovascular disease, many of the world's leading medical societies in cardiology and endocrinology updated their clinical guidelines with this newest scientific evidence. In March, the American Diabetes Association updated its 2019 Standards of Medical Care in Diabetes. In September, the European Society of Cardiology and the European Atherosclerotic Society updated their clinical practice guidelines for the management of dyslipidemias. And just a few weeks ago, the National Lipid Association issued a position statement based on the findings from REDUCE-IT. With regard to ICER's economic analysis, Amarin understands the many complexities of models which frequently rely upon multiple and disparate data sources and numerous assumptions. The limitations of approaches such as Markov models, which project clinical, economic, and humanistic outcomes for simulated cohorts of patients over time, are well documented. For these reasons, I would like to share Amarin's thoughts on a few key ways in which ICER's economic analysis could potentially be threatened in order to more thoroughly capture and elucidate its cost-effectiveness and budget impact. Amarin believes that it's essential to use all of the evidence from REDUCE-IT in the economic analysis, including number one, using all 5 components of the pre-specified primary endpoint in the Markov model base case analysis, and 2, using total event data. We believe it is beneficial to use a patient-level microsimulation approach to modeling and incorporating more recent U.S. national cost data for cardiovascular events. As a result of the strong scientific evidence from REDUCE-IT, Amarin feels that it's critical and appropriate to include all clinical endpoints that are statistically significant and clinically meaningful impacted by icosapent ethyl into the base case cost-effectiveness analysis. While ICER's base case model contains treatment-specific events for myocardial infarction and stroke, as well as all-cause and cardiovascular-specific death, REDUCE-IT reported statistically significant findings for coronary revascularization and for hospitalization for unstable angina. However, these medical events were not included as treatment-specific events in the base case model from ICER and were only incorporated in a scenario analysis. In REDUCE-IT, 16 hospitalizations for unstable angina and 76 coronary revascularization procedures were prevented per 1,000 patients treated over a 5-year period. Despite ICER's analysis reaching favorable conclusions based on select events, these data represent clinically meaningful and statistically significant benefits for patients, as well as cost offsets for payers, and should be included in the base case cost-effectiveness and budget impact analyses due to the high quality of this scientific evidence. We also believe that recurrent long-term downstream cardiovascular events after the first cardiovascular event involve real costs to patients, payers, and society, and need to be included in the model. REDUCE-IT provides robust patient-level data for the effects of icosapent ethyl, not only in preventing a first primary composite endpoint event, but also in reducing total cardiovascular events. Each component of the primary endpoint was reduced by icosapent ethyl therapy in a statistically significant, clinically meaningful, and economically relevant manner. The cost of recurring cardiovascular events are both real and impactful to society, and they should be reflected in the analysis. While we understand that Markov models that simulate the clinical, economic, and quality-adjusted survival outcomes for cohorts of patients over time are a valid and accepted methodology for economic analysis, and that a cohort simulation was likely the only way that ICER could conduct the analysis, given that they did not have access to patient-level data from REDUCE-IT, we believe that a micro-simulation approach will permit a more accurate assessment of the cost-effectiveness and budget impact of icosapent ethyl, and the data is available for such analysis. Finally, we observed in several places within the ICER report that older cardiovascular disease event costs were inflated to 2019 values using the healthcare component of the Personal Consumption Expenditure Index and used in the economic analysis. Although inflation adjustment is a valid approach in health economic analyses, it may not fully account for actual changes in costs over time. And we believe that more recent cardiovascular disease event cost data from a national economic medical record and/or claims database would provide more up-to-date cost estimates to allow for a more accurate estimation of the cost effectiveness and budget impact of icosapent ethyl. On behalf of Amarin, I again thank ICER and the Midwest CEPAC for the opportunity to be here and to be part of an open dialogue around the clinical and economic benefits of icosapent ethyl to patients, payers, and society. Amarin is dedicated to working with relevant stakeholders to ensure access for eligible and appropriate patients to innovative, life-saving, and quality-of-life enhancing therapies. Thank you.
Thank you very much, Dan and Alena. Brett or David, do you have any response initially, and then we can field some questions from the CPAC.
Well, in terms of the modeling, so there were a few points there. One of which is the patient level versus the cohort level. Just to address that, there's a whole literature base that compares patient level versus cohort level modeling. Ultimately, the conclusion is when we're coming up with a base case, value-based price estimate, there's really not a lot of difference between the modeling methods, and there shouldn't be. And then certainly we welcome additional analyses and publications and to see if the answer is different, but we're pretty confident in our result. I think the other comment was on inflating costs and then the use of other data sources. I think we're challenged with the ability during 8 months to generate claims analyses and actually pay for these databases. If you're familiar, a lot of databases that are owned by commercial entities, and it costs quite a bit of money to have access to those. So it's a challenge in our field, and the cost estimates that we use were actually recently published just, I think, this year, actually, in 2019. So we're using cost estimates that, at least in the literature, are up to date and in 2019 values. Was there anything? Do you want to?
The only thing, and it applies to the model as well, but in some of the comments, and maybe in that statement as well, there seemed to be this blurring between the fact that we're not looking at a total event analysis and that we're not looking at total events. We're absolutely looking at total events. We're just applying the hazard ratio for the first event to the decrease in likelihood of subsequent events. We're not using the total event analysis that was published, but we are absolutely in the model looking at total events.
Jason or Jeremy, did you have any follow-up comments from Dan or Lena's?
I don't at the moment.
Okay.
I just want to clarify, because there's been a lot of confusion with how to address the DAPT. And obviously, those comments painted a fairly broad brush to what in practice is a fairly specific situation, right? So the COMPASS trial had a very broad inclusion criteria. It took lots of people who had CID, whereas the current indications for DAPT are often very specific based on, have you recently had a stent? What type of stent have you had? Have you had bypass surgery? And the trials supporting those vary. And both the analysis we saw and your comments sort of treated them as one big broad thing, which of course in practice is not the case. And so that is why you can accurately say DAPT is not indicated in the COMPASS population when of course it's indicated in some subsets of the COMPASS population. And so I think that at least helps clarify some of the confusion there. Beyond that, of course, DAPT is currently used in these circumstances, and for most of the COMPASS population, it's a 2B indication, right? If you look at the ACC guidelines right now, there's some evidence, but not certainly as strong as the large randomized trial of COMPASS. But I felt like the comments there were sort of confusing what was a situation that was a little different than presented.
Dan, do you concur with that, or?
Sure. I can understand the compelling reason to make that comparison. However, if you look at the two trials that the recommendation to compare DAPT to the COMPASS patient population of Charisma and Capri, at best, Charisma failed in the overall population. So it is not considered, the COMPASS population, which is chronic and stable, is not the same population as the typical clopidogrel patient, which is following ACS or a stent, and it's usually within 6 to 12 months. The guidelines typically recommend 12 months unless you have a bleeding issue, which would be 6 months. Once you're chronic and stable, it's no longer considered an appropriate comparator or therapy in this patient population. In COMPASS, the mean time from your last myocardial infarction to inclusion was 7 years. There's no evidence whatsoever that that's the appropriate patient population for DAPT or clopidogrel. If you look at the DAPT study, which was a large number of patients who recently had a stent implanted, comparing the 3 antiplatelet agents, but primarily clopidogrel and prasugrel, there was a mild reduction in events, primarily reduction in myocardial infarction, presumably related to the stent, although half of the benefit in those settings had nothing to do with the stent. But there was also a signal of increased mortality. The FDA took the unprecedented step a couple of years ago to remove the comments about reducing mortality from the clopidogrel label. That's not the case here with rivaroxaban in this dose range. There is a robust reduction in stroke, myocardial infarction, CV death, and there was also a parallel reduction in total mortality with a p-value of 0.01. So I don't think comparing clopidogrel and rivaroxaban is a reasonable comparison, particularly when this type of document is out there for decision makers about what might or might not be covered under a formulary. I think that's putting the patients second.
David?
Yeah, I just wanted to be clear that we looked at a subset of the COMPASS population for this comparison, those who have had an MI in the prior 2 years. We didn't look at the people 7 years out to compare to DAPT. And we also, within the DAPT trials, some of them went further out, and we looked at the subgroup within those 2 years so that we were doing our best to compare apples to apples there. Again, I described where there were concerns in our ability to do that so well, but we didn't do what was just described, which was compare a chronic late population after MI to an early post-MI population.
Jason, did you want to?
Yeah, no, I would just point out, I think, I agree with some of your comments, especially about your hesitation about the network meta-analysis and some of the comparisons, and I think that's well articulated in the report, that it's just very, there has not been a randomized control trial for secondary prevention in aspirin and low-dose rivaroxaban versus dual antiplatelet therapy. I guess I would just point out, so you referenced the DAP trial, and you also said that there's no evidence at 7 years, which is correct. There is evidence up to 30 months, right? So that is a heterogeneous population, but as you've pointed out, there's reduction in stent thrombosis, reduction in MI, even MI not related to the initial stent in a population that was heterogeneous, both with respect to MI versus stable for PCI indication, but also heterogeneous with respect to the choice of dual antiplatelet therapy use. I think it was mostly clopidogrel, but some prasugrel as well. Right, so, but in clinical practice, a lot of us use dual antiplatelet therapy, including beyond 30 months, as a way to risk reduce in patients that we think are at high risk. The secrets, the basic clinical decisions that we make, and I know I'm confounding this a little bit because of the stented population and the not-stented population, but the basic clinical decision we make as people become farther out from an acute event or some sort of sentinel stress test or something, is assessing their risk of recurrent MI, and that one of the mechanisms that it happens is through thrombosis and sort of thinking about platelet function. And we generally escalate regimens when we think they're at higher risk, if we think they're at lower risk of bleeding. The problem is, of course, a lot of the people who are at high risk of bleeding are also at high risk of thrombosis. The dual antiplatelet score has some ability to disentangle that. But the basic, I think the basic, I'll just say as a clinician, a lot of us don't use rivaroxaban in this setting, in part because we don't understand the comparison with dual antiplatelet therapy.
It's a great discussion, and I would love to keep it going. We have 3 public commenters that we need to bring up for about the next 15 minutes. So I want to welcome Andrea Bare, Taylor Kelly, and Marie Warshauser. Oh, I'm sorry. Yes, I already know you're there. I'm sorry.
It's okay. We're here again.
You're here again. I knew we're bringing only one more up. My apologies. And so same as before, we have about 5 minutes, 3 to 5 minutes for prepared comments, and then the conversation will certainly continue. So why don't we start with Andrea, are you ready to go, or Marie? If you're ready? Andrea?
Yeah, sure. I don't know what we...
If you're...
Okay.
Great.
Okay. Thank you. As you know, I'm Andrea Bare, with the Executive Director of Mended Hearts. I am also a mother to a child with heart disease. He was born with congenital heart defect. And I am a sister of a brother who has had multiple heart events in his young 29 years. So the fact that I have been invited here to talk today, I'm very appreciative of, and I would like to not comment on the clinical information or really a lot of the analysis that have been brought today, but I would like to put this in a perspective from a patient for you. As you're reviewing and voting on this, I would like to just leave a couple of comments for you. True shared decision-making is really vital in the role that the doctor and the patient plays, and the ability for the patient to be able to make the decision with their physician on what the treatment of care should be is really what drives our advocacy efforts, because I believe that if it's there and it's improving the quality of lives in the specific patients that we're looking at, the ability for the patient to be able to access that medication is really vital. And so I always am very hesitant to judge on a clinical effectiveness or a cost effectiveness, I should say, to take a population and just throw them all into one big bucket and say, well, this should be cost effective and so we should be able to cover it. When in fact, if it's one specific person that this is helping and it's been shown effective and it's been shown to be safe for them to use, then this should be covered for them to be able to use specifically to that patient. And so I am not sure the implications of if we say that this is a great outcome and this is something that the doctor should be able to give, then the important part is that the doctors are talking to their patients about this. And so I think that that's a completely separate subject. But the communication of the true risk and the whys in clear terms for that specific patient is what's really vital, in my opinion, above and beyond the cost benefit, because this does not show in the real world how it may work, because we're not going to be throwing all of the patients in one bucket and saying this is what everybody has to use. And I think that that's really important to understand. If this is going to help 10 patients or 25 patients or 1,000 patients, if it's safe and it's effective for that patient in reducing the risk of these cardiovascular events, then that's what we should be focusing on, not in, is this going to help every single patient? Because we need to have that shared decision making, and all of the options need to be on the table for the patient, and they need to be given that option in very clear terms. So that's what I would say.
Thank you. Marie.
To echo when Ellie was talking to me about why I was here, I think I have a different perspective than many of you. Why am I here? 18 years ago, my life changed. In my early 30s, I was busy raising 3 boys, exercising, eating healthy, and just living a busy life. However, my heart had other ideas. After several trips to my doctor complaining of being exhausted, having numbness radiating down my left arm, and feeling short of breath, I was diagnosed with coronary artery disease. I had 99% blockage of my LAD. Angioplasty was performed unexpectedly the day of my stress test. I had a list. I needed to get moving. 5 months later, my stents had closed, bypass surgery followed by several months of rehab, all while adding on to our home. My life, my family's life had changed. Why am I here? As one of the first women to participate in Women's Heart's Science and Leadership Symposium, I learned that the science of my disease, as well as understanding that it was also a disease that touched my confidence, emotional balance, and depth of understanding for what I am now living with. Understanding that I would forever be on medications that might cause side effects or damage other organs made me to sit up and wonder, why is this medicine not made to help my heart? By participating in research programs, drug trials, and other advocacy movements, I am learning and helping. Why am I here? In 2005, just as we were getting ourselves settled after my diagnosis, my husband is diagnosed with a meningioma. His easy surgery was anything but. After a month in the hospital and weeks in a rehab center learning to walk, swallow, and talk again, our home became a full-time healthcare center. I was no longer the patient. I had become the caregiver. The navigation of the medical world as a caregiver is a very different experience. It was truly an eye-opening experience, eye-opening adventure. My husband and our family has endured 10 years of medical chaos and disconnected care. We quickly learned the ropes and had the ability to seek additional advice and speak up. Our nonstop research and inquiring about treatments or drugs that might work held hope for us. We sought out holistic treatments, acupuncture, therapeutic massages, exercise, and meditation, all in the name of trying to make a difference. Sadly, the disease won. I am here to make a small contribution to something that I would hope help others navigate the world of medical diagnosis and the path that will make us feel better.
Thank you, Marie. Taylor.
Good morning. My name is Taylor Kelly, and I serve as a policy advisor to Aimed Alliance, a 501c3 nonprofit health policy organization that works to protect and enhance the rights of consumers and providers. I'm also an employee of DCBA Law and Policy, a health law firm, and Aimed Alliance is a client of DCBA. On behalf of AIMED Alliance, thank you so much for the opportunity to speak today. AIMED Alliance appreciates that ICER has deemed icosapent ethyl and rivaroxaban to be cost-effective. However, we are concerned that ICER's value-based framework may compromise patient access to therapies that have been shown to be innovative, life-saving, and responsibly priced. We'd like to reiterate some of the points in our comment. First, thank you for acknowledging the patient perspective and including indirect costs of productivity losses in your analysis. However, ICER does not appear to incorporate these important considerations into its value-based benchmark prices. As such, we remain concerned that the framework does not adequately capture the full value that these therapies provide to patients. Also missing from the value assessment is data on icosapent ethyl from 2 of REDUCE-IT studies' primary endpoints, coronary revascularization and hospitalization. These are meaningful endpoints for patients in terms of cost effectiveness and disease management and progression. Their inclusion would certainly impact an accurate assessment of the value of innovative CBD treatments and should be included. Moreover, the report does not adequately incorporate the risk of subsequent adverse events in its analysis. The report explains that it assumes that the risk of subsequent events would be the same as that of a first event, but it is unclear that this is an appropriate assumption. Subsequent events can be costly and increase the complexity of treatment options and disease management. Therefore, it is critical to include appropriate and accurate information about all adverse events into a cost-effectiveness analysis. Despite not incorporating this data into the benchmark, we are pleased that ICER has deemed the 2 therapies to be cost-effective and responsibly priced. However, it is concerning to AIMED Alliance that ICER simultaneously recommended that the drug manufacturers significantly increase the 2 therapies' prices and that health plans restrict access to the 2 therapies to such a small portion of the eligible population. ICER recommended price increases of up to 39% for rivaroxaban and up to 149% for icosapent ethyl. It had also explained that only 6% and 4% of eligible patients should be treated with rivaroxaban and icosapent ethyl, respectively, in a given year without crossing the ICER budget impact threshold of $819 million per year. We are concerned that these recommendations may impact patient access. While payers may still choose to include these therapies on their formularies, they may also choose to impose restrictive policies, such as prior authorization and step therapy, in order to align with ICER's recommendations. Step therapy policies require insured individuals to try and fail on alternative treatments, sometimes with adverse events, before the payer will cover the prescribed treatment. Prior authorization policies require providers or insured individuals to obtain approval from an insurer or its pharmacy benefit manager before the plan will cover the cost of a prescribed healthcare product or service. Such policies can be unethical and inconsistent with standards of care, interfere with the patient-doctor relationship, and result in significant delays to prescribed treatments. Consequently, while ICER's report does identify rivaroxaban and icosapent ethyl as cost-effective, it is quite possible that the downstream impact of this report will still compromise access to innovative therapies designed to treat a disease that is the leading cause of death in the U.S. As such, we recommend that ICER change its recommendations. Instead of recommending price increases for a small fraction of the CBD population, we recommend keeping prices as is and allowing a larger population to access these treatments. Finally, AIMED Alliance reiterates its long-standing opposition to the use of the QALYs. QALYs can result in inappropriate healthcare rationing and discrimination based on age and health status, unfairly favoring younger and healthier populations. QALYs put a price tag on the value of human life that merely reflects the individual's diagnosis and deems those with chronic, debilitating, and rare conditions such as CBD as being worth less than the rest of us. Despite long-term stability without disease progression, patients are never valued as whole. Thank you again for the opportunity to speak today. AIMED Alliance is grateful for the opportunity to provide the patient perspective and the evaluation of the cost-effectiveness of these additive therapies.
Thank you so much, Taylor, and thank you so much for coming to be with us, all of you to be with us today. Are there any comments from the CEPAC?
Sure, I just wanted to say briefly, ICER did not recommend price increases. ICER did not recommend that coverage be restricted to 6% of the population. Those would be misinterpretations, and I know there'll be discussion this afternoon with the policy roundtable about how to deal with the potential budget impact and making sure that patients who need these drugs get them. And that finally, the QALY doesn't value human lives, it values treatments. It looks at the value of a treatment, not the value of a human life. And as we heard, when all you did, for instance, was look at how much these drugs lengthened life, you missed the importance of them actually improving life as well, which shows how important it is to use something like the QALY when looking at therapies. Thanks.
Thanks. That's great. Any comments or questions from the CPAC? I know that some of these comments will definitely come up this afternoon. I hope that you're able to stay around for the policy discussion, because I think it'll be pretty rich. This is clearly an issue where step therapy and prior authorizations are probably important to make sure that you get a rational distribution of the product. But how you implement that is clearly, of an important discussion.